25 minutes on AMEQUIS and then 15 minutes of questions and answers. Thank you.
So this is my first try at doing this in a condensed, simple way. So hopefully you can give us your feedback at the end, but we've got Q&A at the end. I've tried to break AMEQUIS down into bite-sized pieces, so I'll get on with it. So this is probably one of my favorite subjects, which makes me a nerd, I think. We all have our moments. So today I'm going to talk a bit about an overview of the AMEQUIS process, and then do a deep dive into assessment, monitoring, evaluation, and the quality improvement. And there's a Q&A session at the end. When we talk about AMEQUIS as a framework, there's some core reference documents which we will always go back to, and the AMEQUIS framework stems from. So just to remind everyone, these are the key documents. There's a cross-border healthcare directive, because that's a legal basis for the ERNs to be established. There's a delegated decision, an implementation decision, which is the specific framework which the Commission then set up, which sets out the what and the how the networks should be organised. And then the third sort of suite of documents which are important in the AMEQUIS framework is the original application form of the ERNs for your ERN, the grant agreement which the ERNs have with what was Chafea and now HIDAIR, and the supporting operational criteria. The operational criteria here elaborates the core criteria or standards which are in the legislation here. And this legislation is an elaboration of what is in the directive, so they're all connected. Going back to the beginning, the ERNs were set up under the Cross-Border Healthcare Directive, and in that Cross-Border Healthcare Directive, they said that networks needed to achieve one of 3 out of 8 objectives. Each ERN had a choice in its application to choose which objectives their network would want to achieve and tackle in the first 5 years. So it could be that Reconnect picked that they would contribute to pooling of knowledge regarding sickness and prevention, maximizing cost-effective use of resources, and about research and epidemiology data. So in the AMEQUIS framework, each network will be assessed based on their specific objectives they identified, and each network would have picked different ones. So I ask you, do you know what the objectives of your network were in the original application? If not, go back and find that out, because that will be one of the North Stars to guide this process. Quality improvement. AMEQUIS is a framework to drive quality improvement, and I just wanted to set out the principles of quality improvement. The guiding principles. They're here on the left, and basically improvements should be continuous and incremental. So they're not improvements which take place at any one point in time, but it's a continuous process of improvements. That's what the framework tries to do. That everyone involved in that system has a responsibility for quality improvement, whether it's the network coordinator, the project manager, the healthcare provider, the board of member state representatives, or patients, or the Commission. That everyone involved in this should be respected to contribute and work in partnership, and to ensure that we have a healthy culture of quality improvement, and that goals and metrics must be clear and aligned. If the goals and metrics which are being developed in the AMEQUIS framework, the ERNs, aren't valuable or relevant to the operationalization, day-to-day management of the ERNs, then they're not aligned and they're not useful. They're pointless. So it's important that the measures and goals are relevant to the day-to-day activities of the network. And that standards which are set are necessary, but they should always evolve and change, because once you increase standards, you're pushing the expectation of services and the networks to meet that new standard or that enhanced standard over time. There's different types of quality improvement approaches. We talk a lot about the PDSA, that's Plan, Do, Study, Act, Sigma 6, Lean, and this one, Diablo, or whatever model, which is what we will look at in a minute. So what is AMEQUIS? So the A in AMEQUIS is for assessment. The M in AMEQUIS is for monitoring. The E in AMEQUIS is for evaluation. And together, assessment, monitoring, and evaluation, when they work together as a system and the elements in each are aligned, create a quality improvement system. So each one of these aren't standalone activities, but they should be aligned so what happens in assessment can be used in monitoring and can be used in evaluation, then makes this the quality can improve across the lifespan of the networks, as opposed to these being individual hurdles to be jumped in time or requirements to do. So the strength of this is about the interconnectivity of each of these elements. Assessment. The evidence base is here. I'm not going to read all this out to you. You've got it in the slides. But basically, assessment should be a dynamic process which stimulates quality improvement rather than a hurdle to be jumped at a point in time. You know, setting up EURORDIS, everyone had to do the application. Everyone had to do their own application to join EURORDIS. It's something to be done as an administrative thing, which has no value beyond, yes, Great Ormond Street can join, and then it becomes bureaucratic and a waste of time. So assessment should be focused in a way that has value to the functioning of those services and the networks on an ongoing basis, and we'll focus on that in a minute. There's a strong association when assessment is focused on the right thing, that it improves the quality of services, it improves the outcomes of patients, and it reduces clinical variation of the people involved in that service. In fact, the assessment grade, the grade or the mark or the achievement in assessment can be a predictor of clinical and service performance. And what's really important is that patient involvement in the assessment process improves the relevance of that assessment in care, in the day-to-day care. So if you're involving patients in the assessment of ERNs, and therefore what you're doing is you're looking at going to a hospital, let's say Care in Paris, and going, how is this centre being involved in this network improving care, and looking at the care which is provided. That makes it more relevant to the clinicians involved and stops it being an administrative thing and starts to be more focused on going, okay, so is that what we should be doing, or what are the standards here? So it gives the focus more on what's important to the clinicians. So clinicians and hospitals can see, if it's not done right, that this is a hurdle to be crossed at a point in time and adds very little value. But the published evidence is to push it as an assessment as a quality improvement scheme that progresses over time. Any assessment framework which is newly established will never stay the same. Year on year, it will evolve, mature and develop. So when we look at maybe an example of a new assessment system, let's say in the Netherlands, for being recognised as an expert centre, the assessment which was done 5 years ago to the new one now, the standards have been increased, the thresholds for being recognised as an expert centre has been developed further. So it pushes the assessment that people going through this system have to improve and demonstrate improvements to maintain their competency. The most, normally when a new assessment framework is set up, there's not a threshold which is put in. You normally see how everyone who goes through that scores, and then you get an idea of how the market performs, to then say the next year to put a threshold of 70% achievement or 85. The most mature system I've seen for assessment of expert centres is in Sweden, which doesn't measure, do you meet these standards to gain accreditation or designation. They actually do it on something called outcomes. So to be recognised as an expert centre in Sweden for lung and heart transplant, you actually have to show your clinical outcomes of surgery are the best. So that is a very mature way to do assessment of centres. You can't start off with that model. You have to start off with something simpler and build and evolve. What we know about assessment is that there's lots of different ways to assess models for assessment, which are here. All of them have positives and negatives. There's not one which is best. So what we find is in assessment, it's best to use a mixed model approach. So you could have, this is what we did in the ERNs, a self-assessment. So I assess myself against some standards before submitting, and then having someone else, like the ERNs themselves, peer review my assessment of how I see myself performing against a set of standards. So they validate that. And then there's an independent validation of the peer review of my self-assessment. So we're able to triangulate 3 types of assessment to see whether they say the same thing. That optimizes, that balances out those pros and cons for each of these models and sort of negates it. What's key is the effectiveness of a mixed model approach for assessment is dependent on the sample methodology. So if you have 10 centres, 100 centres being self-assessing and only 10 centres get peer reviewed, and of those 10 centres which are peer reviewed, only 10% of them are independent validated, that means that of the original 100, you're only having that mixed model approach to validate through self-assessment, peer review and independent validation on 1 out of 100. So sample sizes and how you target that sample size is really important. For the assessment of the ERNs, working from the Cross-Border Healthcare Directive, we have the delegated decision. In the delegated decision, you have Appendix 1 and Appendix 2. They set the conditions and criteria for the networks to fulfill for new networks and for the HCP applicants to fulfill to be a member of a network. So these are the list of the domains, as it were, for the criteria for networks and HCPs. We use this to develop some more detailed operational criteria, which were able to be used for people to do self-assessment against. The specific criteria which was included in the legislation were only able to present an approach, a methodology for setting those specific criteria. So these specific criteria were defined at the network level to be fulfilled at the HCP level, based on the conditions that network was covering. So in the EUROCAN, it could be that the number of interventions to be an expert in sarcoma and soft tissue would be 50 surgeries of bone sarcoma a year or 100 soft tissue. There's an active caseload of patients, a minimum which is required to meet that threshold. So that's a really important key aspect of the assessment. These are the detailed measures here of the delegated decision, the criteria in the legislation for the networks to fulfill. So at a network level, they have to fulfill 42 measures, which are underneath 13 criteria based on these areas. I think these are really good documents to look at. They're available. For HCPs, they have to do a total of 27 criteria, which expand into 68 measures. Some of these measures are specific to the team, and others are more general for the hospital. The assessment process for ERNs is under 8 stages. You can see here in stage 2, that's where you do your self-assessment. In stage 5, that's where you do your peer review. And in stage 6 is where you have the technical assessment, which is the independent validation. The threshold for a positive assessment for the networks, this is based on the revised assessment framework in AMEQUIS, is a compliance rate for networks of 50%. It was previously 70%, and a minimum requirement of 10 HCP members from 8 member states. For HCP applicants to join an existing network, the standards have stayed the same, the threshold, 70% achievement of the general criteria and 80% of those specific criteria I just gave examples of. It's a whirlwind tour of AMEQUIS. I'm going to move to monitoring. Monitoring, if the indicators which are agreed for networks to monitor aren't relevant to the operational day-to-day management of the networks, then it's pointless. But if they are relevant and have a value which gives the networks something to see how they're progressing, then it gives them an opportunity to see on an ongoing basis, are they going in the right direction in achieving their main goals? And if they're not, it gives them time to take corrective action before we get to an evaluation at the end of 5 years. And we realize that we set this goal at the beginning from the Cross-Border Healthcare Directive. How far have we progressed to achieving that? And the monitoring gives us that opportunity to take action and corrective action if needed. The evidence base says that when you identify what can be monitored, that the act of measuring alone can be viewed as a stimulus to improve quality. So getting the networks to focus on an outcome measure or a process measure or a structural measure, which is this model here, is really key. The best thing is to get, if you've got the clinicians in, let's keep with EuroCan, the sarcoma clinicians to monitor the outcomes which are disease specific of their patients going through their system, then that gives those clinicians, that stimulates quality improvement in clinical services in the care they're given. So if they monitor their infection rates post-surgery, their survival rates, and their other clinical outcomes, then it enables them to take action and improve based on their clinical care. But if you're asking them to look at process or structural indicators, then that's more, that probably has a more separate, these are more proxy measures for to improve outcomes, whereas outcome measures are the best in my view. But for some areas you don't have that, so you have a structural measure as a proxy, as an indicator for to improve outcomes. The ERN networks developed, a network coordinator group developed a continuous monitoring framework at a HCP level. That was that they had to maintain their monitoring of how many new patients they were seeing on an ongoing basis. The ERNs developed some core indicators which were common across all ERNs, and I'll share them with you in a minute. This monitoring framework which the networks also developed also included disease-specific outcome measures, which therefore simple disease-specific measures could be developed for each of their conditions in their networks. I would say by and large, those outcomes, disease-specific outcome measures weren't developed overall by most networks. Some have. I think in ERN they monitor them and they put them on the registry, which is great. That gives them direct feedback to take action about their care and informs how they deliver their services, which is brilliant, but it's not been implemented across the whole ERN system. And then evaluation at 5 years is actually monitoring. It's just monitoring the time span is over a bigger period than these 18 indicators, which is monitoring on a 3-month or 6-month basis. These are the 18 indicators which were common. All the networks have been collecting over the course of the past 5 years. There is some issues, I believe, in the consistency of how these are being reported against. So you've got here about new clinical practice guidelines. There's real variation between the networks of how many new guidelines are being developed in their networks, because potentially the definition for how they're reporting is slightly different. They've tried to tidy that up over the last 2 years, but I think there's still variation. But you can see the ones in pink, the patient level satisfaction and number of guidelines adopted, they were never implemented in practice. So we've got 16 which have been monitored against. So the new AMEQUIS framework, this continuous monitoring framework had been updated. And one of the key shifts in this was that the monitoring wasn't going to be just the network coordinator's responsibility. Monitoring of performance of the ERNs going forward is a shared competency for the coordinators, the HCPs, even member state representatives have a role and responsibility in monitoring, now related more to a new indicator on how the networks have been integrated into their system. And the patient representatives in the ERNs also have a role now in monitoring. So it's a shared competency. These are the domains of the indicators, the 18 indicators I've just shown. And the new framework, which hasn't been published yet, we believe that the indicator domains have evolved like this. So we potentially will be moving from 18 to 20. The new one is on integration into healthcare systems. You can see research has increased from 2 to 3. And patient satisfaction, that one measure from patient satisfaction which wasn't implemented before, has been expanded into 4 key areas. So you can see the shift of monitoring, the importance of monitoring on how patient involvement in the networks is being activated, and around the patient-centered care approach. So I think that's as much as I can say about the new framework, the new indicators at this time. E for evaluation. I'm checking the time and I'll speed up. So evaluation is a big hot topic. We need to, what we know is that patient experience and satisfaction in service quality is important as a predictor for survival. So having patient experience and satisfaction being evaluated in a service actually is connected to the performance of the service in terms of maximizing on patient survival and outcomes. So there's a direct relationship to that. So patient involvement in the ERNs and their experiences will be a predictor for quality as well. So I think the new framework which is being developed has positioned the patient voice in that process as very center stage, I would say. We mentioned at the beginning that all the ERNs are different in size and scope. They're picking different objectives to achieve. So the evaluation needs to recognize the difference. So we were very successful in our advocacy with the EPAG community that we shaped the evaluation framework, that one key aspect that the report on each of the ERNs evaluation would highlight the structure of the networks, the maturity of the networks, the activity the networks have done, and the impact the networks have achieved in the 5-year period. This enables the reports from the 24 ERNs can be differentiated between impact isn't based on all the networks being perceived to being the same. It gives a way to sort of reference differences. So I think this is a really good model. And this was based on the Health Foundation model for effective networks. The evaluation framework, which is available for everyone to see, and we can share that following this webinar. At a network level, the networks will be evaluated whether they've accomplished those 3 recommended objectives from the cross-border healthcare directive. Are they still fulfilling the criteria and conditions set out in the delegated decision? They'll evaluate and assess the outcomes and performance of the networks, looking at the monitoring which has taken place over the past 5 years, those 18 indicators. They'll look at the grant agreements. What did the network say they'll do? They'll look at samples of the deliverables being developed as well. At a healthcare provider level, members level, the evaluation will see whether the HCPs continue to provide specialist and quality care. Do they maintain the necessary level of activity and experience against the specific criteria to continue to be in the network? They'll assess what the contributions of that HCP team have been in the network and the value the ERN has been for the HCP member as well. So I think that's, so here you can see performance could be looked at, looking at more quantitative measures from the 18 indicators, and here about value and contribution, that's more qualitative. These, going back to the slides earlier, I mentioned about the operational criteria for assessment. So the AMEQUIS Consortium took them and refreshed them for evaluation criteria. So there's clear alignment between the 2. The difference is that the evaluation focuses on standards which have enhanced practice. So have the networks at a network level contributed to research? Have they got a registry in place? Yes, we have a core registry in place, tick. Have you got a core registry in place which collects clinical outcome measures specific to a disease level, to a specific disease? That's an enhanced practice standard. So you'll be able to see sort of the maturity of the networks, and these criteria are available now. So you'll get a sense of maturity of the networks, but there are some very key core measures. So for a network, there's 20 criteria broken down into 52 measurable elements. Of those 52 measurable elements, 30 are core, means they have to be achieved. The same with the HCP members, 24 criteria, which expand into 64 detailed measurable elements, of which 29 are core. The timeline for evaluation is approximately, I believe, 12 months. What's important, if in the legislation, whether the Commission organises this with the network coordinators might be different, but the legislation says it is a responsibility for the network coordinator to request within the first 5-year period an evaluation from the European Commission. So that needs to be triggered by the network coordinator. The Commission works with the ERNs coordinators, so it could be that they standardise that they do it as a point in time, but the legislation says it should be triggered by the coordinator. It's a responsibility. There's the preparation stage, the self-evaluation stage, the technical evaluation, and the results. The preparation stage is about involving the network members and being clear about this process. Self-evaluation is by the network themselves and the HCPs using a self-assessment tool against the evaluation criteria, which I've just highlighted. And then the technical assessment will be one which I'll cover in a second. So technical evaluation is in three parts. The first bit will be, there'll be an online meeting between the evaluation body and the ERN coordinating team and the work package leads or the thematic leads in the network to review the self-assessment that the network and the members have done. Then the core team, the evaluation team, will review the self-assessment themselves and look at the justification of the compliance which has been reported by the network and the members. They'll do a documentation review as well as reviewing the self-assessment, the self-evaluation. This documentation review will go back to the original applications, what was set out there that the networks would say they would achieve. They'll review the monitoring indicators, the 18, over the past 5 years. They'll review the grant reports and a sample of deliverables to see whether this self-assessment justification is evident in what was produced and submitted. I mentioned about patient experience is central to this. The patient representatives in the networks will be invited to take part in interviews to also be to say about their level of participation in the networks and their involvement in the governance and strategic planning of the networks. So I think that was a real success. There'll be an evaluation report for networks and HCPs. I'm not going to go through this, but the key is it's not about having a positive or negative result. It's about whether it's a satisfactory result or whether there's areas for need improvement. I'm sure there'll be areas for need improvement because some of the criteria in the evaluation framework, in the operational criteria for evaluation, those are enhanced standards based from the original application, from the original assessment. So meeting these new evaluation criteria will highlight the level of maturity and the need for improvement where necessary. So I think all networks will have an improvement plan in some way because it's part of the quality improvement principles. And these plans will be put in place and submitted at the same time as the reports. So bringing together assessment, monitoring and evaluation together as a quality improvement system, by you can promote improvements through the small actionable cycles that over time create a thread of quality improvement from the original application, assessment, monitoring through to evaluation. And those together create this system. Just to be clear, the AMEQUIS system as a whole hasn't been published. I'm presenting what has been published on the revised assessment framework and the revised evaluation framework. Monitoring hasn't been published yet, and neither has the whole framework of how it all works together as a system. So this next bit is me trying to give you an idea of how a thread of quality improvement through these pillars can look. So this is an example, and hopefully I've got 2 examples and then I finish. So the first example is if you take the objective at a network level, back from the Cross-Border Healthcare Directive, there's an objective to facilitate mobility of experts, to help member states with low numbers of patients, populations affected, to be able to provide highly specialist healthcare themselves. Not everyone will have enough patient populations and cases to build the competencies themselves. So that was an objective. The ERNs should be able to facilitate that sharing of knowledge to those countries with lower population levels. So in assessment, you've got at an ERN level, this was one of the key things most networks highlighted. They say the rationale for setting this network up is because of rarity and complexity, there's not enough of this expertise everywhere. So it gives a rationale for forming the network because of the complexity and rarity of the diseases we cover. In monitoring, the indicator is to monitor how many reviews on the CPMS system How many people have been submitted to that? And also how many of the member states have affiliated partners in the ERNs? To be an affiliated partner, it's because you haven't got enough of a population size to be a full member to have the competency. So the number of affiliated partners gives an idea of how much the networks are facilitating the mobility to these other countries which don't have a big enough population. So the number of cases, the number of members who aren't full members builds on this need for having a network because of rarity and complexity. And so over time, these numbers and how they creep up and increase would show the impact of the ERNs ultimately. So the evaluation would look at will evaluate how the collaboration strategies with these affiliated partners have been. Have they been silent members? Have they been active in the discussions? Are they able to take back the knowledge of the ERNs back to their country? That will be assessed. They'll see about, is there referral systems and information for people from for member states where there isn't a full member to get access to that expertise? That will be a part of the evaluation. So ultimately, the quality improvement bit through these stages should see that we've optimized the availability of the existing expertise and knowledge that can be accessed locally to all EU citizens, therefore driving quality in local services. This is my last slide, Ines. So at a HCP level, an example of how this quality improvement system can work. We have that the networks will facilitate improvements to diagnosis and delivery of high quality of care, particularly where there's a requirement to concentrate expertise. So the assessment, we have to be a member of a network. This is for Gentoris. Maybe you have to have a caseload of NF2 patients of 250 a year. So that's at this point in time. That gets monitored on an ongoing basis to see whether those numbers of cases being referred to HCP members have increased. By having visibility of recognition of being a Gentoris centre in the network, have you started to have more of an active caseload because more patients are coming to you and being referred to you? So that gets monitored on an ongoing basis. And in evaluation, the team will evaluate whether the competencies are still being met in the ERNs. And the quality improvement of this is that increased volume of cases has been demonstrated to directly lead to improved outcomes of care. So the more, if you go to a hospital which sees 500 patients as opposed to 5, the outcomes are better because the team is able to build a greater body of knowledge. So by having this system in place, we should be able to see a growing number of cases, people being seen, and the expertise and competency of that centre being increased, which leads to the quality improvement, which is improved outcomes for patients. That's it. How did I do for time? I probably went over.
No, it was, I mean, yes, a little bit, but thanks for that. And I always learn new things when you present this. So I'm really grateful for the effort. Is there any question? We have a little bit of time for questions and we can go a little bit further if people can stay. Susanna, I see you. No question? Yes.
Only say thank you, Matt. This was very useful. It's an overview of the AMEQUIS system. So, sorry, I think it's very useful. Thank you very much, Matt. It's only that.
Thank you, Susanna. If there's no question,
I have a question, if it's okay. Sorry, it's waiting. So, we said that the AMEQUIS should go over a period of 5 years. You're saying we are working on the new framework, etc., etc. But has the first evaluation of the ERNs been done now? Because I mean, they are existing for 5 years now, right? Or what is the plan for the evaluation?
So we're not quite at the end of the first 5-year cycle. We're approaching it quick. Then the European Commission have done a tender to appoint an evaluation body, so that the framework's now developed. They're appointing an evaluation body who will then come in, use the standards and framework I've just highlighted to evaluate the networks. I have a feeling it's probably going to be next year that starts to happen. We haven't got confirmed timelines, etc. Yet, but I think there's a bit of a bridging issue around the end of the 5 years to refreshing the mandate for the next 5 years. But I think that's for the Commission to manage that slight bridge.
Yes, Nicole.
Maybe could you explain if it's a difference between the results of the healthcare providers? For example, in a network, there are some of the healthcare providers who are not fulfilling the criteria, but at the whole, if you look at the whole thing, they have, let's say, 22 points, but one of the healthcare provider maybe has not a good performance. What happens then, or is it only counted in total? Do you understand what I mean?
The healthcare, I don't know the sample size of how many healthcare providers in the network will be evaluated. I don't know that that's not been published. But the performance of the healthcare providers and the networks will be measured individually. So it could be that that some have an improvement plan to step things up. I find it really interesting that the HCPs will be asked and evaluated around what's been their contribution over the last 5 years. I think that's great, because we have had some very active members and some more quieter members for various reasons. But I think that's an important thing. If there is a performance which is questionable, I haven't really seen. I'm sure that there is a process for improvement, and if not, then for reconciliation of the membership of the ERNs based on the outcome. So I think there's been a termination policy which is being looked at by the ERN coordinators themselves. I don't know the status of that yet, but I think there is this mixture of active members and inactive members, which I think part of this process should either renew the commitment and involvement or reconcile the membership. I don't know whether I answered your question, but.
There is also a comment from Eileen in the chat. She's saying,
oh, Eileen, yeah, super. Yeah. I think that all HCPs will be evaluated through an online portal, but only a fraction will have on-site visits yet. The performance, if the performance is not satisfactory, networks or HCPs will have to provide an improvement plan. Yeah, which is what I highlighted. Yeah. The question is then, after a year, then how does that trigger, and what's the process for if the improvement plan hasn't been completed satisfactorily, then what happens? That's the bit I don't know.
May I put on the spotlight to Jessie? Jessie, I'm sorry. We have 1 minute left, but can you maybe just in a minute explain what we're trying to do with patient experience with care, so that people understand that this is a long-term project and that it won't be looked at this time in this 5-year evaluation, but further, you know, in the next one, let's say. Go.
Yeah, so there's, as Matt said, there's an indicator on patient satisfaction, or rather now I think it's recognized by the Commission that it would be patient experience for it to be measured within HCPs and for the ERNs. And so what we've done already at EURORDIS with 4 ERNs, with ERNet, Eurogen, Lung, and Gentries, is to do a pilot to see how we could measure patient experience. And that's actually through a specific questionnaire that doesn't exist yet for rare disease. So we have to develop one so can be used by the ERNs and by the HCPs within ERNs for their monitoring. So we are both working on a research point of view to be able to develop this questionnaire, and still discussing with the ERNs to fund the development of this PREM, actually patient-reported experience measure. And also at the same time discussing with the ERNs and with the Commission recently to make sure that this PREM would be included within the AMEQUIS system. So either into the monitoring, but in that case, it would be measured every 5 years, or in the evaluation. But yeah, that's what we're doing now. So the idea would be that the questionnaire would be ready by 2026. So for the next funding scheme, anyway, to develop the questionnaire, we have to do a survey. So we have to measure patient experience. So we would have a first measure. But then the idea would be to do it regularly every 5 years to see how it improves within HCPs and for the ERNs.
So it's patient, so just to clarify, patient experience with the care that they receive in the centers of expertise.
Exactly,
Thanks for that, Jessie. That's super. So yeah, Matt.
I just want to check. I think it was Angela who laid down the gauntlet for someone to try and make AMEQUIS digestible. Hopefully I tried my best, but you'll be the judge whether I achieved what you wanted.
Matt, I think is brilliant. And as much as you know about the subject, of course, it's easier to condensate. Is in certain way difficult, but in another way more easy to present something. I would say possible to be understandable for other participants. And it's a very good support we can use to disseminate the knowledge inside our ERNs to other patient organizations, and so to give really the culture of this ongoing quality improving system, which is fantastic.
So the reason why I'm a real nerd when it comes to quality improvement and assessment is I worked for 14 years in the NHS in the UK, and I saw how monitoring stuff in healthcare was completely irrelevant and bureaucratic. And then for 3 years, I did national commissioning where we didn't monitor those boring stuff. We just got the clinicians to identify 2 or 3 core outcome measures which told a story about a condition. And we made sure that each of those centres did 100% data completeness of those 3 or 2 measures, which told a story about the care they were given. And we made sure that each year those centres came together and shared their outcomes in the same way. We didn't have to have it in a system, a registry or anything. They just had to present it so it can comparable. And what that did was it enabled those experts to know when one practice was better than the other. What are you doing with your under 5 sarcomas? Ewing sarcoma, you're getting better infection rates. It enabled that discussion. And then the people will be able to say, well, we're doing this. And everyone started to then evolve their clinical practice based on being able to see when one practice was better than the other. In the time I did that job, I saw improvements to clinical outcomes of patients with no active treatment by 20 to 30%. Just because the experts shared their knowledge together and had a way to compare. So a health system or an ERN system can monitor stuff. The question is how much does what it focuses on and what they focus on can mean that it can be really useful improving the outcomes of the people you care about, or it can be administrative and bureaucratic. And for me, the real push for this, for AMEQUIS and for each of the networks is to move to that disease-specific outcome focused to enable discussion by these experts for liver transplantation or for PBC or you know, to improve their practice by sharing. And I think if that is the value, and that's unlocking the potential, and that's why I'm a big fan of this type of system. The question is, how much have we moved the AMEQUIS system forward to focus on the right things? And I think we've moved forward, but I think more needs to be done.
As always, thank you, Matt. And I need to close now the webinar. Thank you all for your time, for being there. Hopefully it was
Thanks,
useful.
Matt.
Bye-bye. Bye, everyone.
Thanks.
Bye.
Bye-bye.
Thank you.
Bye.
Yes. You can disseminate the recording. You can share. It will be in our YouTube